Hello and good evening. I'm happy to be back here with you because I know some of you have already joined our very first event tonight. And of course, today with us is Dr. Diana Obidniak. You can see her right there already. Hi, Dr. Diana.
Hi everybody.
Hi, how are you? Hope you are having a good day.
Sure. I am so grateful for this opportunity. I would like to thank the organizations and to thank Egg Nation team for such a great initiative. I think that facing such kind of tough times, we should really be together because it indeed makes us stronger. I'm sure that we
Definitely.
can go through all this dramatic situation and win this COVID-19.
Perfect. That's exactly what we think as well. So thank you for joining us. Of course, Dr. Diana also is from AVA-Peter Clinic, which is located in St. Petersburg. And she is also the head of the International Cooperation Department there. So she will today start with her presentation. But before that, again, let me just show you that, of course, the Stronger Together initiative is also, without the partners, without the ambassadors, we wouldn't be able to simply do it. So here you can see all of the people that are actually helping us as well, with all, I mean, of course, with all the top experts like Dr. Diana as well. And you can see all the partners below too. So thanks for that, for sure. And as I've mentioned, Dr. Diana will start with her presentation. And today our topic is endometrial receptivity, programming IVF success. So she will explain everything on that topic for you. And right after the presentation, Dr. Diana will answer your questions. And as always, you can type in all the questions in the chat section, and Dr. Diana will be happy to answer them, I am sure, and will be happy to help you out as much as possible right now, of course, as well. So that will be it from me. And well, Dr. Diana, are you ready to begin?
Yeah, sure.
Fantastic. Go ahead then.
Thank you. So once again, good evening. I would like to discuss with you, for me, very, very important topic called endometrial receptivity, programming IVF success. So at first, what do we possess? What do we understand? What do we mean when we talk about IVF success? For sure, for my team, for I bet all the fertility specialists across the world, actually we understand that our mutual IVF success is when you take your healthy baby home. I want to explain you that our understanding of this KPI of the whole process had changed. For example, even 5 years ago, at all the fertility conference meetings of reproductive area specialists, we aimed that our goal is to achieve the pregnancy, to help our patients to make more family happy. But afterwards, when having more advanced technologies, when having more types of ovarian stimulation. By the way, we have more than 19 types of ovarian stimulation. So we can be sure that we can perform individualized treatment. But when having more and more tools for making more pregnancies, we had got the understanding that it's not our real aim. Our aim is not just to get pregnant. Our aim is to hear the sound of this chilling of the baby at home when your baby, healthy boy and girl, is running across your flat. So this is our real goal. But as you know, good beginning makes a proper ending. That's why I would like to describe you from the very beginning how your pregnancy initiates. And in the very beginning, we should talk about implantation. Implantation is the process of delicate interaction So it's this initial interaction between the embryo and the endometrium. And traditionally, for many, many years, and all our physicians across the world had education, and that we thought that there are just two players, embryo and endometrium, involved in this delicate process. But just about 8 years ago, a group of investigators demonstrated that there are much more participants. For example, there are so-called cumulus cells, microenvironment, and various growth factors. And precisely these participants play an important role contributing or hindering successful nidations. So, we should understand and we should know and meet these main players talking about successful implantation and seeking the reason when we face to implantation failure. So generally, we should investigate and assess the competence of embryo, endometrium, and concomitant pathology. Interestingly, that a human being has a very specific feature. In human being, we have a rather high rate of abnormal, so-called aneuploid embryos. What does it mean? If you have ever had IVF cycle, I bet your fertility specialist had interpreted all your medical reports, and you have seen the medical report on embryo development, when we observed how the embryo grew from the very first day. And on day 5, we expect to see so-called the stage of blastocyst of the embryo. So the very stage when the embryo can implant and result in pregnancy. And on that day, we have to assess the external appearance of the embryo. And for many years, in our arsenal, we had only so-called morphological evaluation, when we assessed external appearance, making some signs according to international classification. You have seen at your medical report, there are some signs using figures and letters. For example, 4AA, 3BB, 3CC, and when making interpretation for our patients, when providing information about the quality of these embryos, we often use such kind of adjectives like excellent quality, good or average quality, or even poor quality of embryos. For us, physicians, this type of classification for many years was the crucial point, the crucial thing when selecting the embryo for embryo transfer, because we wanted to optimize for sure the protocol, and we wanted to transfer the embryo with better potential for implantation. That's why we for sure wanted to transfer the excellent embryo, or at least good embryo of a good quality. But when pre-implantation genetic testing have become widespread technology and actually is one of the routine techniques in our practice, excluding some countries which have law limitations, law restrictions of using this technology. These restrictions are not associated with medical issues, it's just associated with some historical aspects and just general opinion. But even in those countries, we see that the policy is moving to accept this pre-implantation genetic testing technology, because precisely this technology provides us more information, and we can see that sometimes even the embryo of the excellent quality is not genetically approved. And on this slide, I have presented the data with the big data. Don't think about they were presented in 2017, but it's by this time the largest data we have. And you can see that even if you see on the slide, if you look at the slide, even among the embryos of the excellent quality, only 56 and 4% are genetically approved, are genetically normal. If we look at the embryos of good or average quality, only approximately 40% are genetically approved. What does it mean? If we do not perform pre-implantation genetic testing, we will rely only on external experience, so the looking of the embryo, and we can transfer that embryo, producing, unfortunately, ineffective embryo transfers or, unfortunately, pregnancy with some specific features, with problems, with health problems on the embryo. But by this time, for sure, we have a solution. Nowadays, if we talk about good clinical practice, pre-implantation genetic testing is widely implemented. And for us, it's a great basis for selective transfer of one embryo. Because even when we talk about transfer of two embryos, I know that in some countries, fertility specialists still perform such procedures. We increase the risk of multiple pregnancy. But I would like to tell you, as a professor, the tutor at the university, because I'm not only fertility specialist, I'm also OB-GYN specialist who I'm responsible for so-called difficult pregnancies across Russia. So I have a lot of dramatic histories associated with multiple pregnancies. That for us is also a great tool to provide safe service, to make your pregnancy safe and comfortable. But if we talk about normal pregnancy and great IVF cycle, you should understand and you should take into the account that even when we have genetically approved embryo, unfortunately, we never achieve 100% of success. Why? And this situation, we should remember that we had another main player, Endometrium. Traditionally, for many, many years, Endometrium was considered just as a passive partner. You know, like a just place where the embryo is placed, where your pregnancy is to be initiated. And there are some arguments for this position. For example, we have already observed embryo development up to day 14 in conditions in vitro without any connection with the endometrium. And to say the truth, we could observe even longer embryo development even for much longer period of time. But for sure, we had to stop because of ethical aspects. In natural life, I bet that you know the cases of so-called ectopic pregnancy, when the pregnancy is initiated not in the uterus, for example, in uterine tube. And you understand that there is also no connection with the endometrium. So is there a real need for endometrium to make the pregnancy? Actually, we have a deep understanding of the role of endometrium in implantation. By this moment, we understand that endometrium is a microenvironment which consists those stimulus cells, those growth factors, and which contribute the pregnancy or hidden the implantation. Endometrium is a natural biosensor of embryo quality because endometrium is characterized by two capabilities. The first one is to accept the embryo. We call it receptivity. The other one, the antagonist of the first capability, is so-called selectivity, when the endometrium catches the information that the embryo is not genetically normal, and as a defense, as a natural defense, endometrium hidden this implantation, trying and making all its best not to produce the implantation and progression of the pregnancy. So normal endometrium, uncompromised endometrium, has the balance between receptivity and selectivity. But this harmony is very fragile, and it can be affected by functional and morphological alterations. When we talk about morphological alterations of endometrium, we usually think about very evident things like hyperplastic processes. Maybe you have heard, we call it polyps. So it represents like extra tissue plus tissue in your uterus. Another one type of pathology is intrauterine synechiae. It's like connection, adhesions between law of uterus. For sure, these kinds of pathology we can observe even during routine examination, making routine ultrasound. There are some specific signs with a rather high objectivity, so we can see these signs of the pathology. But we should take into the account that these processes are the result of another pathology. Both of them are usually the complication, the logical result of inflammatory process. I would like to tell you that this inflammatory process, it's not an acute inflammation. We call it chronic endometritis because it's a latent type of inflammation, so it doesn't provide general harm, general threatening for your life, but unfortunately it provides great alterations in your uterus. So I would like to provide you, international understanding of the term of chronic endometritis. It means a condition involving the breakdown of the peaceful coexistence between microorganisms and the host immune system in the endometrium, resulting in a special type of chronic inflammation in the endometrium characterized by non-apparent clinical signs. Well, making interpretation from medical terms to common language, I would like to explain you. So it means that this inflammation is only in your uterus. It's involved only the internal lining, the endometrium. And it results in clinical manifestations which are not that apparent as you can expect. For example, you can notice that your menstrual bleeding has some specific features. For example, it's not red bleeding during 3 or 4 days, which we consider normal character of menstrual bleeding, but you may notice some brownish bleeding before the beginning of the menstrual bleeding or just after menstrual bleeding. It's the sign from your organism that there is some kind of pathology in your uterus. We have just to, catch this information and hear our organism. For example, if you brush your teeth and you notice that there is bleeding or you feel pain, for sure you will understand that something is wrong, and you will make an arrangement with your dentist, or you will buy some therapeutical solutions or therapeutical toothpaste. You will react. The same thing in the whole organism. Your organism always tries to pay your attention to the focus, to the area which is affected. So in case of chronic endometritis, these signs are very, very non-apparent. The process is latent. So there is no threatening of your life, but there is great alteration in your reproductive area. That's why, unfortunately, in many cases, the first manifestation, the first complaint of patient with chronic endometritis will be infertility or several ineffective IVF attempts. If we talk about prevalence of chronic endometritis, you see that the prevalence will differ depending on the focus group. If we will investigate general population, we will not observe more than 10% of case of chronic endometritis. But if we will study a group with unexplained infertility, we will observe threefold higher incidence. It will be approximately 30%. In group of recurrent implantation failure, when we have good quality of transferred embryos, but unfortunately the pregnancy was never achieved, we see even 60% of prevalence of chronic endometritis. And for sure, in very difficult group of patients with recurrent pregnancy loss, with dramatic history, we expect to observe this pathology because we identify and we confirm the prevalence of chronic endometritis in 66%. That's why, given these data, given intensive experience, given all the guidelines, national guidelines from European Society, American Society for Reproductive Medicine, Australian Society for Fertility Specialists, and Russian Society, we have implemented in our practice a great protocol, standardized protocol, when we implement golden standard of investigation for chronic endometritis. It means that in case of unaffected implantation failures, ineffective implantation, IVF attempts, or recurrent pregnancy loss, we always perform hysteroscopy as a golden standard of diagnosis of endometrium. While making this procedure, we insert very thin camera into the cavity of the uterus. And then we can assess the conditions, because your uterus is like a kind of apartments for your future pregnancy, for your future embryo, for your future baby. That's why we should prove that the condition of this apartment is perfect, is optimal for the implantation. So the good thing is that if we find any troubles, we can fix it just at the same time under great visualization. But unfortunately, it's not that simple in all cases, because if we talk about all the alterations, we should remember that we also have functional type of alterations of endometrium, and we should talk about compromised implantation window. What is that? Surprisingly, but endometrium, the tissue which is intended to accept the embryo, unfortunately has the opportunity and is ready to accept the embryo only during very short phase, only during 48 hours during the whole menstrual cycle. So we need the synchronization of the processes of embryo development and the maximum endometrial receptivity. Unfortunately, we cannot see if there are some alteration concerning implantation window using routine methods of diagnosis during hormonal lab tests or make an ultrasound examination. So we need to make advanced diagnosis. By this moment, we have two approved test systems, ERA test and so-called Be Ready test. It's a technology which provides us the information about the best time in your personal case, the best time for embryo transfer, when precisely your endometrium is ready to accept the embryo. We call it personalized embryo transfer because it makes personally given your individual data. These are data comparing outcomes in a standardized group of patients who had undergone frozen embryo transfer, fresh embryo transfer, and personalized embryo transfer. You see that the groups are standardized on age, BMI, the number of embryo transferred, and I want to pay your attention that the age of patients who were included in that study is perfect, is super good, is just 32 years old. So all these women were very young. That's why we observe a great pregnancy rate in groups performing conventional frozen and fresh embryo transfer. So there are approximately 60% per embryo transfer. But even in this good group of patients, when we apply personalized embryo transfer, the success rate is just magnificent. It's 85.7%. For sure, it's the great result. For usually nowadays, because it's still minimal invasive, but it's still invasive method. So it requires performing biopsy, taking the biopsy of the endometrium, and then to assess the expressions of many genes, more than 200 genes. So we usually recommend it not for everybody, but in case of unexplained infertility or in case of recurrent implantation failure, not in case of recurrent pregnancy loss. I would like to give you some samples of analysis report when we make Be Ready test. So these both tests are just quite similar. I really don't see some that one of them is better. Just Be Ready is the ERA test was the first technology, and Be Ready made quite similar procedure, but is a bit more affordable in financial expenses. But their outcome is rather comparable. So I just wanted you to give these examples to see that how we see the results. When having the result, obtaining the result, we see a kind of scale with the score. When you see that the score is, you see here, 138, 60. In normal situation, normal pattern, we expect to see approximately 100 of activity. If we see pre-receptive like this kind, so endometrium is not ready, is not mature, is not ready to accept the embryo. Sometimes we see the kind of post-receptive result. It means that endometrium is already over-matured. So the window of implantation is already closed and endometrium is preparing for menstrual bleeding, for desquamation. It's a crucial point. And I really, as I'm specialized, my practice is specialized in recurrent implantation failure, I'm pretty satisfied with this examination because we have great results. Many patients with ineffective previous attempts, I mean that they had even no molar or biochemical pregnancy, so they never have seen positive HCG. Always, sometimes we have patients with 11 or 12 IVF attempts in their history, and they never have seen positive HCG tests. For us, when we analyze the data and we see that PGT testing was already done, we assess the endometrium and we see that endometrium in morphological terms is really good. And but unfortunately, there was no positive HCG in the history of that couple. We always think about precisely this alteration because when we make embryo transfer in standardized recommended protocol, because this standardized protocol was performed was implemented, according to our understanding, that 65% of women have normal time frames for implantation window. It means that we should make embryo transfer on day 6 after the beginning of progesterone administration. But sometimes, it's not really sometimes, it's 35% in patients we are not placing on the right time. And it means that even good embryo, when placing on wrong time, will have no interaction with endometrium, because endometrium will just not see it. It will not catch it and will not try to accept it. So it's a very important point now. But for sure, we want to make more. For us, for the fertility specialist, for each member on my team, I know that physicians, nurses have tried to emotionally get pregnant with each couple, with each woman. So unfortunately, sometimes when we have no positive results, for us, it's also very stressful. That's why we can relate, we do relate, and we want to make as much as possible from the first attempt. We always want to make some guarantee cycles, to make more implementations, more actual tools to improve the efficiency. But to say the truth, we don't have too much therapeutic tools which are approved by evidence-based medicine. According 40 years history of IVF development, many technologies were suggested. Maybe you know them. I bet you have heard about scratching, about human immunoglobulin, about even acupuncture. But unfortunately, if we talk about evidence-based medicine, it's not approved. There is one method which has a great basis and which is approved, and even we have meta-analysis. It's the best level of evidence. Is the implementation of granulocyte colony stimulated factor, growth factor, G-CSF. Why it's so useful and important? In natural life, it's already produced in our organism, and this growth factor is involved not only in implantation, but it plays a very important role in maturation of eggs, in inducing the process of ovulation, and for sure in the process of implantation. And this meta-analysis has shown that in group with G-CSF treatment versus placebo, the implantation rate and clinical pregnancy rate was much and significantly higher. What next? What can we do more? Unfortunately, sometimes we face two very difficult problems when we cannot make endometrium competent in morphological issues. For example, when we talk about adhesions, intrauterine synechiae, its connections between loss of layers of uterine. Maybe you have heard such term Asherman syndrome. So there are strong adhesions. It requires surgical treatment when we make division of these connections, but unfortunately on these places where connection were, unfortunately we expect to see a very poor growth of endometrium. And according to big data, we know that we need at least 7 millimeters of endometrial thickness to have a good implantation rate, to have successful result in IVF program. So what can we do? Because if we cannot fix this problem, unfortunately, we expect an ineffective result. Sometimes when we cannot fix this problem, we have to apply surrogacy program, but it's always a very difficult decision for everybody. That's why we want to be sure that we have done our best. We really have done everything. So what can we do more? Nowadays, a great area in medicine is called regenerative medicine. You know that actually patients, physicians, usually, and all these kinds of evidence-based medicine require prescription of certain medication, but sometimes drugs are already powerless. And we should remember that we have our own resources. And when we talk about regenerative medicine, there are two directions of development. One is so-called stem cells, I'm sure that you have heard about this stem cell therapy, but unfortunately, by this time, it's still under investigation. We have in many countries and in Russia also, I'm a tutor at the university, and we have a lot of study works and trials investigating stem cell product, but it's still under experiment. We cannot implement it in our routine practice. We cannot recommend it for you, even if we know that it can help you. Unfortunately, the state of development of this area is not that high to recommend it for you. But another direction of regenerative medicine is so-called PRP therapy, platelet-rich plasma. The strategy of using autoplasma, so we use your plasma, not plasma of somebody. We use autoplasma with the aim to improve and accelerate the regenerative processes caused by the growth factors contained in the platelets. There are many of them, including precisely G-CSF, granulocyte colony-stimulating growth factor, but also in our platelets, there are a lot of more growth factors: insulin-like growth factor, platelet-derived growth factor. I want to explain you how it works. For example, if you have small injury on your hand, or you have an injury by your dog or by your cat, you never start taking antibiotics or medication to stop the bleeding. You know that your organism will fix it, and you need nothing else except your natural resources. It works when you have good immune system. So the injury provokes the signal in your organism that you have precisely in that place injury. And there is a migration of the platelets on that place. And precisely on that site of injury, platelets release alpha capsules, which contain all these factors. So our idea was to derive these platelets in autoplasma enriched with these platelets to the site of the endometrium injury. So when to the place where endometrium is not appropriate. Some years ago, we have performed a trial, and we even received some awards and patent on the invention. It concerns patients with recurrent implantation failure and with the thin endometrium, so two groups of difficult patients. We have demonstrated that if we perform infusion of this platelet-rich plasma into the uterus, we see that the pattern, the structure, and the thickness becomes much better. And if you look at on the site, you see that the rate of clinical pregnancy is double higher than in control group where was no intervention. So it's really a good method to increase your chances if you have indications. And also, I would like to share just two case reports of our practice. The first one, I had a woman, a patient of 39 years old. In her medical history, we observed one abortion, one right-sided tubectomy because of ectopic pregnancy. So it was the secondary infertility. Unfortunately, before successful experience, she had 8 embryo transfers. And if you pay attention, 6 of them were performed after pre-implantation testing, genetic testing. So she already had transferred good embryos, which I approved. After the second one, she had hysteroscopy and endometrial biopsy. According to the result of endometrial biopsy, her physician had seen signs of chronic endometritis, but unfortunately, no conservative treatment was conducted. What we have done, as we already had embryos, we understood, and they were already approved, even her age. She has a rather risky age because after 35 years old, we always expect increased level of increased risk of abnormal embryos. But we already had good embryos, and I understood that before experience in our clinic, she already had 8 embryo transfers, and the quality of embryos was approved and confirmed. So what we have done, we performed hysteroscopy, and if you see on the screen, you see this extra tissue on the uterine angle. This precisely how polyp looks like. So and unfortunately, why I wanted to pay your attention to this case. Sometimes when the polyp is located in such position, in such place, very close to the beginning of uterine tube, unfortunately, sometimes it's like a blind zone. We cannot see this pathology by ultrasound. So sometimes physician can just not detect this polyp during conventional examination. So we have deleted this polyp. We had done immunohistochemistry to identify if there is chronic endometritis, and unfortunately we confirmed that there is a severe activity. It means that this inflammation is rather active, because sometimes when it is long-lasting, the activity is not that low, is not that high, so we don't need to prescribe antibiotics to minimize the inflammation. But in this case, we have to prescribe antibiotics, and we also perform 2 cycles of PRP therapy. And on the following cycle, it was the second cycle after hysteroscopy, so the following cycle after the therapy, she had spontaneous pregnancy, and we had a very, very good baby. So I have a lot of pictures of that baby, because for me it's a very great reminder that there is a lot of resources in our organism. We always should think that sometimes our organism is much smarter than our medication. So we always have the chance for good. Another case, also the patient of 39 years old, 11 embryo transfers in her medical history, 6 were fresh ones, and 5 embryo transfers were frozen ones. Endometrial preparation was always using hormonal replacement therapy. Also, if we talk about features of her medical history, she had endometriosis, severe stage of endometriosis, stage 3, chronic endometritis with severe activity and autoimmune component. We also have observed, it's a rare situation, presence of anti-endometrial antibodies in her peripheral blood. So we changed her stimulation to a moderate one. As I have already told, we have a lot of kinds of stimulation. By the moment, we have 19 types, so we can make it really individualized. So we made embryo banking with following PGT, and then delayed frozen third embryo transfer in natural cycle with PRP therapy. Here is no mention, but precisely in this type, in this case, we have used error test. So we made personalized embryo transfer. And additionally, just because it's a very rare situation, we have used human immunoglobulin, but I have mentioned that there is no evidence-based. It's not a tool of evidence-based medicine, but here we had an indication because she had autoimmune component, and we had detected the presence of antibodies in peripheral blood. So this is the only indication when we can prescribe this human immunoglobulin. So as a result, the first embryo transfer after the therapy was successful. We had clinical pregnancy and delivery via cesarean section, just because of her problems with eyes. So there was no connection to gynecological history. So what about take-home message? For me, implantation process and the reproductive function in women in whole is a symphony orchestra. Endometrium for sure is an active participant. It's not a passive partner. This endometrial receptivity should be assessed before planning embryo transfer. And unfortunately, we really have a very limited number of therapeutic methods. At the end, usually I wish reproductive success, but nowadays, I really want to ask you to take care about yourself, about your close people. I hope that this tough time will stop soon, and we really should be together this time. I'm very grateful for your attention, and I'm ready to answer all your questions.
Fantastic. Thank you so much, Dr. Diana, for such an informative presentation and providing with all of us so many details on all of those aspects. And yes, it is definitely time for our questions. We do have lots of questions already, so let's get to it, of course. And here's the first question. How would you grade a 3BB embryo in terms of successful pregnancy? Is a 3BB embryo a good embryo or a poor embryo? How do you explain that a BB embryo implants and leads to a live pregnancy following in vitro on a natural cycle with a 43 years old, whereas with a 39 years old woman, it stops growing? So question number one, what can be the issue here? Question number two, can a natural cycle or a frozen cycle make a difference? Thank you.
Great questions. Thank you for the very, very good questions. So for sure, 3BB embryo, according to this international morphological grade, is a good one. It's not the poor. It's a good one. But as we had told in the beginning of presentation, there is a very slight correlation between this external appearance and internal competence, genetic competence. And for sure, 3BB embryo can be, it's just 40% that it will be genetically normal. But for sure, it still be. And for sure, there is a correlation with the age. So for sure, in most cases, the patient at the age of 43 years old will be considered with lower chances than a woman of 39 years old. But it's not that simple, because we should take into the account AMH level, the number of antral follicles by ultrasound, the general somatic status, because for sure reproductive area is not separate system in our organism. If a woman has some diseases or she has to take medications which can affect the quality of eggs, unfortunately we do not obtain a good embryo even in very young patients. For example, in patients with diseases of kidneys who require intake of very, very harmful medications, for sure we expect a bad, poor quality of embryos. Also, some gynecological diseases like endometriosis can also affect the quality. But if we talk about the block, the so-called embryo arrest, when the embryo doesn't grow properly, it usually associated with the quality not only of eggs but also of quality of spermatozoa. So we need to assess, to investigate, and to examine both partners for sure. So unfortunately, at the age of 39 years old, we can observe such kind of embryo development when most of them, or all of them stop. But I need more information how many follicles were obtained, if this patient had surgeries on ovaries, and a little bit more about medical history. If we talk about the difference, the second question, the difference between natural cycle and frozen cycle. There were plenty of trials comparing the results and outcomes of natural cycle and frozen cycles. Most of these trials with good design, with big data, with a large number of participants in the trial, demonstrate that there is no difference in outcome. But you should take into the account that when we make so they are both frozen embryo transfers, I think, but one we make in natural type, so we do not prescribe any hormonal medication, and during the protocol of hormonal replacement therapy we have to prescribe some kinds of hormones. For sure, it's stress. For even when we make it very, very delicately, it's still the stress for the organism. And sometimes patients have contraindications. We do not allow us to prescribe this medication. So for sure, in this mode, the natural cycle will be the first line therapy. As to me, I prefer to make everything more natural. And even when we have a very strong standardized protocol for each situation, but always I tell to my patient, sometimes less is more. So I bet in medicine we should avoid additional interventions when it's possible. So when we can make in natural cycle frozen embryo transfer, we should make it in frozen embryo transfer. But if the question was comparing natural cycle, egg retrieval in natural cycle or egg retrieval in ovarian stimulation, for sure we have a lot of arguments that egg retrieval in ovarian stimulation cycle is much better. I hope I have answered.
Perfect. Thank you so much for your question, as well as helping out here as well. And actually, we have a next question from the very same patient. So let me show you that one. So I had a frozen in vitro implantation with a 3BB embryo, was successful. Clinical pregnancy confirmed by ultrasound. However, no heartbeat. Week 6, baby stopped growing. In the week 5 biopsy of the embryo confirmed me that my endometrium is okay and no diseases. What do you suggest for me for a future in vitro?
Well, for sure, this type of cases inquire pre-implantation genetic testing. Unfortunately, it's one of unbenign scenario of the history when we make embryo transfer or 3BB. As I have told, it's considered as a good embryo, good quality of embryo, but we have no information about its genetic competence. And in this situation, when embryo is abnormal, sometimes when endometrium catch this information, it just there is no implantation. But in some cases, and it's about 20% of pregnancies, unfortunately, the pregnancy will stop. So your organism will fight and will make natural defense and will not allow pregnancy to progress. That's why, unfortunately, women sometimes face to miscarriage experience. And we observe this pattern when pregnancy initiated, but unfortunately is interrupted approximately from week 5 till week 8, is always associated, not only, but in 90%, so in most cases, it's associated with genetic problems. So I think that there is a great chance that the reason of miscarriage was associated with the genetic problem of the embryo. But as to quality of endometrium, at first, one case of miscarriage, if you have great resources of your organism, really can have no complication on endometrium. But to say the truth, in most cases, we expect to see the problems, but not all types of diagnosis can detect them. So, for example, if there was just a so-called histological examination, unfortunately, there is a chance that it was not so sensitive to detect the problem. So we have to implement a special type of staining of this material of endometrium. So it implements, and it's called immunohistochemistry. So because we should catch and we should find the prevalence of CD138 and CD56 to assess the activity of the inflammation, or to prove if there is this inflammation. Unfortunately, other types of diagnosis just cannot detect these CD clusters. So what I would recommend, for sure, I would recommend to make another embryo transfer only after pre-implantation genetic testing, and please check the report of the endometrium diagnosis. Please check out if you had performed really immunohistochemistry testing.
Perfect, thank you. Actually, we have a follow-up question right here from the same patient. CD46, what does it mean?
CD56 is just two features, two signs, so which provide us information. So just special type of cells, of immune cells, which normally shouldn't be. If we have no inflammation, we will not detect them, or we will detect them just in a very, very small amount, for example, 1 or 2. So there are a lot of, there is a special scale, immunohistochemistry. We have, these are types of, it's a lab sign, so-called CD56. So the pathologist who will assess your material should make specific staining to detect these types of cells. And only after assessing this prevalence of these cells, we can make conclusion if there is pathology and inflammation in the endometrium.
Okay, perfect. Thank you so much for answering that question. And now we do have a longer question again, but let's have a look at it, okay? I have a multiple failures with own eggs, only one pregnancy achieved but missed miscarriage in 11 weeks, had donor egg embryo excellent quality in January, which ended with chemical pregnancy. I had all tests done but ERA, which I am planning to do before next frozen embryo transfer, but I have doubts in plan. My doctor prescribed for frozen embryo transfer of Estrofem 2 milligrams 3 times daily, oral Estofem patch 50 milligrams every 3 days, and estrogel once daily topical, then cyclogest twice daily, but for ERA only prescribed estofem oral and cyclogest? Does it matter estrogen or only progesterone? What matters for ERA test? PS, had immunology test done and positive for cytokines and interleukin. Plan is for intralipids and steroids prior frozen embryo transfer. Thank you for that question.
Well, I have 3 points which are suspicious for me, because for sure we always try to find the reason of miscarriage, because yes, as I have told, in most cases, in general, about 80% in the whole cases of miscarriage are associated with genetic abnormalities. If we talk about early miscarriages from week 5 till week 8 is even more, the incidence is even more. But if we talk about miscarriage at the stage of development 11 weeks, and if we know that the embryo has stopped precisely at this moment, because sometimes the diagnosis is very late, so the pregnancy was interrupted much earlier, but the diagnosis and the physician had found out that the pregnancy has stopped only at week of 11. So what I want to say that if the pregnancy was interrupted after 10 weeks of pregnancy, it can be associated not with genetic status of the embryo, but with some problems with blood, for example, antiphospholipid syndrome. The diagnosis and the tactics in these situations are very, very different. That's why we always make investigation after miscarriage of the material, so of this abortion material. So if you have the information about the genetic status of this abortion material, please test us. We will interpret it to you. But because
there's additional information from the patient, yeah?
Yeah, grow around 9 weeks, but bleeding started in 11 weeks. So it also very close to the reason which is associated with your blood. And could you tell us if you had this genetic testing to approve the status of this abortion material? Because if it, Caroline, unfortunately.
Yes, this is the next part. I have no issues with blood clotting. And
they wouldn't test every. I know that unfortunately sometimes there is a decision that it's not recommended to make tests because of the first miscarriage. I really, in the university where I have lectures and I am the tutor, I always ask the physician one question: if it was your daughter or your wife or your sister, would you like to push the patient to have a risk of the second miscarriage? And usually everybody tells that no, we would like to have more information, to have more tools to prevent this dramatic experience. So the good news that you had examination for antiphospholipid syndrome, so it's negative. It will also give us more chances there will be no problems during next pregnancy. Caroline, could you make the first?
Yes, of course. Let me go back to the very first question right here.
So, so my position is just to have more information about the reason of the first miscarriage. But as I have the information, you have already performed examination that you could accept genetic testing. But the second thing that I'm a bit confused, why I'm confused, that you have very high doses of hormonal treatment. So you have estrogen, 2 milligrams orally, also estrogen patch, also estrogel. So these all are estrogens. And usually you should understand that we have to increase the doses of estrogens when we do not observe a proper growth of endometrium. So an inappropriate growth of endometrium, it means that endometrium is already compromised. So we should fix the reason and not try to treat the complication. So my position and my recommendation to move once again before embryo transfer and make hysteroscopy and try to assess endometrium in whole for sure. What about error test? It doesn't matter which kind of test system we talk about. Both variant error test and Be Ready has inquires the standardized protocol. So our idea to make just the same cycle of endometrial preparation. But just so if we talk about hormonal replacement therapy, we start with estrogens. When we achieve a good thickness of endometrium, we start with progesterone. And on day 6, or sometimes we move it, taking into account the previous experience, so just precisely at the time when we could make embryo transfer, we take this biopsy and send the material for investigation. So the idea is to repeat the certain endometrial preparation which we plan to make during embryo transfer cycle. Otherwise, there is no sense, because if we will change the conditions, we will have the different result. Okay.
Perfect. Yes. Thank you so much for your detailed question for sure, but also for your advice. Okay. That's really, really helpful, I am sure. Okay. So let me go to the next question. This one is actually a shorter one. And what about endometriosis? Any comments you could provide on that?
Well, what about endometriosis? It's like it's not a question, it's just invitation for a new discussion, because for sure endometriosis is a great problem. It's a great problem in reproductive area, but for sure the impact of endometriosis depends on the stage of endometriosis. So it's on the outcome, the impact of endometriosis is associated with the development of this endometriosis, because there are 4 stages. The first and the second stage are called superficial, and to say the truth, not all the women. So endometriosis is not the absolute inquiry for indication for IVF. If all women with endometriosis couldn't conceive naturally, trust me, a human being will have no problem with overpopulation, because we had much more problems with fertility. But for sure, when we talk about severe stages of endometriosis, we expect many problems, because endometriosis has a lot of points of effect of its impact. Endometriosis can make bad impact on the quality of eggs, on the quality of competence of uterine tubes, making mechanical problems and making so-called tubal factor of infertility. It also provides formation of endometrial cysts in ovaries, making bad prognosis not only on quality of eggs but also on quantity of eggs. So there are many aspects, and please provide maybe more detailed question, because for sure, and Caroline, I believe it's a very good topic for next for next webinar.
That is true, exactly. So, of course, if you would like to add anything, just go ahead. But actually, we have a follow-up question on endometriosis. So, can endometriosis be detected during a regular gynecological control?
Well, you should take into account that endometriosis can involve different tissues, and there are so-called even extragenital endometriosis, which affects lungs or different or non-reproductive organs. According the conventional gynecological assessment, we make a physical examination, and there can be some focus of endometriosis on the cervix of the uterus. In this case, we can detect it just visually. When we talk about ultrasound diagnosis, there is a very different objectivity if we talk about endometriosis of uterus or endometriosis of ovary or endometriosis of pelvic area. Because if we talk about endometriosis of uterus, we have some specific signs. So the shape of uterus is round. The size is enlarged. The uterus is enlarged in the size, and we have some also specific ultrasound features. If we talk about endometriosis of ovary, we can detect endometriosis by, we can suppose that there is endometriosis in ovaries only in case of formation the cyst, because you should understand that endometriosis is a progressive inflammation disease. We unfortunately have no approved data about the reason of formation of endometriosis. By this time, we have about 7 theories, and the most modern one is so-called epigenetic theory of etiology of endometriosis. So when we know that there is a kind of premorbid phone which provide the formation of endometriosis, but we have no idea what condition will be the trigger for progression of the endometriosis. So the golden standard of approval of endometriosis is surgical diagnosis. So is laparoscopy, when we insert the camera in the abdomen, and with under visual control, we can detect this focus of endometriosis and just delete it just at the same time. So unfortunately, during the regular conventional gynecological examination, we can suppose that there is endometriosis, but we can confirm it only using laparoscopy and hysteroscopy. So when we insert camera into the abdomen or into the cavity of the uterus, only with visual control.
Okay, thank you so much. And actually, there are questions about hysteroscopy. So here's the first one. What's the difference between hysteroscopy and scratch?
It's just very, very different procedures on the basis and different aims. So scratch is just a very, very small injury. It's not the diagnosis. It was scratching. It's when we make a small injury in all the endometrium, trying to initiate a local immune response in this area, because in early 80s there were some data that this scratching can enhance the quality of endometrium, and thus we can enhance our results. And hysteroscopy is the golden standard of diagnosis and treatment. So when we insert the camera into the uterus, and we just enter this under visual control, so we see on the monitor, we see all the internal conditions of the uterine cavity. We can even we can record this video and then show the patient. And during this procedure, we can detect all the pathology and fix it. During scratching, we just insert the catheter. It's a blind procedure. We insert the catheter and trying to just make a very, very small injury in the uterus. So just very different manipulations.
Thank you so much again for answering that question and just explaining the difference. And there's another one here. How do you know when to prescribe antibiotics versus recommend laparoscopy for a patient?
So it's not the kind of versus. There are different indications. So we prescribe antibiotics only in case of detected inflammation. And usually, as nowadays, actual good practice of prescribing antibiotics, we should at first make identification of the microorganism to make this antibiotical treatment not so-called empiric, when we just prescribe medication with a wide range of effect. But when we make a very targeted therapy, and laparoscopy is just another level, of diagnosis or therapy. It has many different indications, so it's just non-comparable things. It's not antibiotic versus laparoscopy, but sometimes after laparoscopy, when we observe and detect signs of inflammation and we have lab confirmation that there is inflammation, because you should understand that any kind of inflammation in any tissue, it's not a clinical diagnosis. Any inflammation should be confirmed by lab tests, especially when we talk about chronic inflammation. So after this approval, after lab test, we make and we prescribe antibiotics if there is need. So it's not it's non-comparable things.
Perfect. Thank you for clarifying that for us as well. And there's another question too, actually, about Be Ready tests, okay, that you had mentioned in your presentation as well. What clinics is Be Ready test available in? And the second one is how is the Be Ready testing actually done? Is this like an ERA test?
Yes, they are very, very similar. So the technique is just the same. We make, as I have told, the similar preparation of endometrium. Both testing system inquire the biopsy of endometrium. So we take the biopsy, and in different testing system has their own cultures where we should place this biopsy sample, and then we send it to the clinics. So the main offices in Be Ready test are located in Tartu in Estonia. We have also office in St. Petersburg, and ERA test is also quite affordable right now, and the labs are also located in different countries. Usually it's just one lab for one country, but for me, talking about effectiveness, they both are very effective. So I don't have any preferences, but Be Ready test is cheaper, and but I don't see any difference according to the experience. That's why our idea is to make our treatment more affordable for patients. That's why for several 2 years, 1.5 years, we have started with Be Ready test. But we still make an ERA test for patients who live, for example, in Spain. For them, it's easier to make ERA test because the main office is located in Spain.
Perfect. Thank you so much for explaining this to us as well. And there's another question here. Can our age sensitization, right? lead to miscarriage?
Yeah, I got the question. Well, no. Resensitization is associated with a severe risk in the last stages of the pregnancy, when we see the conflict between the mother and the fetus. But nowadays, it's not a big problem when we talk about appropriate observation during the pregnancy. So we have the solution, no doubt we have the solution of this problem. So when we have the first pregnancy with rhesus negative mother and rhesus positive fetus, we always have to make the injection of anti-rhesus immunoglobulin at the stage of 22-25 weeks of pregnancy, and then just the second injection will be during 72 hours after delivery. So it's just prophylaxis of rhesus sensitization. Unfortunately, if we don't make this prophylaxis, we can face a severe complication during the second pregnancy. Because I want to pay your attention that during the first pregnancy, we cannot see a severe complication, because the pathogenesis of this process inquire, first meeting of these antigen and antibody. That's why during the first pregnancy, we do not expect great complication, but we have time to make prophylaxis. And unfortunately, if the prophylaxis is not performed, we can face strong complications, but in the late stages of the pregnancy. And it's associated with anemia in the decrease of count number of erythrocytes, so red blood cells.
All right, perfect. Thank you so much again for answering that question. Now we have another question. Can you talk more about the G-CSF? I didn't exactly get what that entails.
So it's a granulocyte colony-stimulating growth factor. It's growth factor which is produced in natural life by granulocytes. That's why we call it in that way. It's involved in many processes in our life, but it has a crucial role in reproductive field. So it controls many things, from maturation of the eggs, because as you know, in women, even in natural life, there is the process of growth of the follicle. There is a process of maturation of the egg, which is necessary to initiate the process of ovulation. And the G-CSF plays a controlling and regulator role in these processes. Also, G-CSF, so the idea is when we have the deficiency of this growth factor, we have some problems. That's why there are many trials when we add in different doses G-CSF during ovarian stimulation, with the aim to increase the competence of the eggs. When we add G-CSF 36 hours before egg retrieval, to increase the rate of mature eggs, because sometimes it's also a rather rare situation, but sometimes during standardized triggering in controlled ovarian stimulation, patient, given their personal features, do not produce mature eggs in normal percentage. So a supplement with G-CSF can fix this problem. But the best results G-CSF has demonstrated when fixing the problem in recurrent implantation failure. There are different types of administrating in mode of intrauterine infusion, but it was the first mode of application, but it wasn't that effective comparing to the subcutaneous way of administration. So by this time, in case of recurrent implantation failure, we administer G-CSF for 2 or 3 days from the day of embryo transfer. But it provokes transient reaction in your blood. It leads to producing of leukocytes, so it should be under control of your physician. So it's normal reaction, but for sure it should be prescribed by your leading physician. So he should control it, everything. But for sure, when it's indicated, it gives very good results.
Fantastic. Again, thank you so much for answering that question. And we do have more questions coming. We will be slowly finishing, okay? But let's get to the next question right here. How can we improve the flow of blood to the uterus? Is it true that miscarriages occur also because of the endometrium not furnishing blood to the embryo?
Well, there was such a hypothesis, such a theory, and you know that there is a blood red in and vessel blood in the uterus. So uterus is characterized by a great flow of blood. And because of its function, so uterus has the capability to enlarge in 500 times. For sure, it has a great blood and vessel red. But I think about maybe 10 years ago, it was a very, fashion. It was in fashion, this idea that because physicians are also has some topics in trend, some topics which are modern. So about 10 years ago, we have we were all excited by this idea that insufficient blood supply to the uterus can provoke problems and can provoke miscarriages. But and after that, there were a lot of trials, and if you see even right now, there are some from small universities or like a first trial of students. They assess these types of blood, but I just wanted to tell you that during these 10 years, by this moment, there are still no reference levels for normal blood supply, because it's so dependent on many features, and we have the information that your uterus has a lot of resources, and unfortunately we cannot assess it objectively, because yes, there are some techniques like Doppler regimen, Doppler mode by ultrasound, but we can see very dynamic levels, and it doesn't provide us good information, good basis of information. So according to actual data, it's not that important. It doesn't have crucial impact, and certainly it doesn't lead to miscarriage. So don't think about that. I'm sure that the reason, unfortunately, is not associated with the problems with blood supply.
Okay, thank you so much again. And there is actually another question on G-CSF. Okay, so we had that question previously, but this is like this one. If using G-CSF to promote implantation, you give it a day of embryo transfer or after?
The very day of embryo transfer. Sometimes it's just one injection. Sometimes it's 3 injections day by day. It depending on the medical history and the number of ineffective attempts and BMI also, because the safe dose is standardized, and we have a lot of information that it's safe, because even in some cases of recurrent pregnancy loss, there are indications for a long prescription of G-CSF even during pregnancy. But as I have told, sometimes less is more. So we never do a lot of intervention trying to make additional stress for the organism. So usually it's just from the day of embryo transfer, 1 doses or 2 or 3 on the following days.
Thank you so much again. Of course, that's perfect. Thanks so much. And here's another question, okay? I have only 17-day 4BB PGS normal embryo in addition to hysteroscopy and ERA. What additional things can I do to make sure I have a great chance for successful pregnancy?
Well, I think that you should believe in success, really. I'm telling with no irony, because I know that, and I bet that you are concerned about that the embryo is of day 7, but trust me, I know that we have the information comparing according to after analysis of big data. We know that the embryo on day 7 has lower pregnancy rate than, for example, embryos of day 5. But you have investigation, you have approval according to PGT. I hope that it was not FISH and NGS, for example, it was by NGS. And I had some patients also with 1 embryo on day 7 approved by pre-implantation genetic testing. And I'm pretty happy to read the information that you have done already hysteroscopy and ERA test. So I know that your physician has enough information to make best for you. You just have to believe in good result. Please think positive. I'm sure that you will manage, and maybe 1 month later you will send us the message that you're already pregnant. I can wish you just good luck, and I'm sure that you will be pretty prepared for successful pregnancy. I will not recommend you anything else.
Perfect. Thank you so much, and definitely fingers crossed. Okay.
Yeah.
And there is another question, a longer one. Okay, and then we have a follow-up right after. So let's have a look at it. Would you recommend test of endometrium prior to embarking on egg donation? I had 4 rounds of IVF with own eggs, but at 43, 45, I've never had a blastocyst. Probably a quality endometrium has always been there, a 3-layer, and people remark it looks good on ultrasound. On one ultrasound, a doctor found some adenomyosis. And let me just go to the next part here. My clinic say no evidence to indicate I need the test, and I could just have standard frozen embryo transfer protocol. I want to be sure, as it's such an emotional and financial investment.
Well, to say the truth, if your physician has a confidence that there is adenomyosis, so there is endometriosis in uterus, for sure there is a great chance that endometrium is also affected by chronic endometritis, because adenomyosis is itself is a chronic inflammation. So in most cases, we see rather severe endometrial chronic endometritis. And the reason of this endometritis is immune inflammation, so adenomyosis. And sometimes it's real true that sometimes, given the ultrasound data, we cannot suppose that there is problem with endometrium, but that's why it's very precious and it's very significant to have a whole information about medical history. For sure, to say the truth, I think that many physicians will make and will recommend you to make this egg donation program without prior hysteroscopy. But as I have told you, we cannot assess and we cannot evaluate the stage of activity without immunohistochemistry examination. And maybe it's not that severe, and in this point, egg donation program for sure has more chances for implantation, but it's not, the type my team works. We usually, our idea is to make one embryo transfer and to have one clinical pregnancy. I always tell that for me, that I explain to my patient that we can get pregnant not after ovarian stimulation, but after embryo transfer. So for us, the most exhausting and the most exciting and the most significant stage is embryo transfer, and we should prepare for it properly. In my point of view, you have already not so light and also pleasant experience. So for sure, I would recommend to make appropriate examination of endometrium. It's not that it doesn't require great financial expenses. I don't see any indications for error test or be ready test, but you should assess morphological, if there are morphological alterations in endometrium, given the signs of adenomyosis by ultrasound. So for sure, I would certainly recommend to make advanced examination of endometrium to enhance the chances for successful implantation in egg donation program.
Perfect. Thank you again for that advice. Okay, as I mentioned, we'll be finishing, and but there are still like a few questions left. I hope we can still get on them, right? Okay. So here it is, the next one. How do immunological issues relate to endometrial receptivity and healthy pregnancy? Can you please explain?
Well, it depends of what types of immunological issues, because there is now we have understanding. Then there is a strong connection, association between 3 points in our organ: is our thyroid, ovaries, and endometrium. So if we have some problems, even with thyroid, we have increased chances with endometrial, also immune defects in endometrium. That's why we should assess if we have this, because immunological issues, immunological defects, in most cases cannot be fixed, because the reason of it is our organism initiates the struggle with our own tissues or organs. So we cannot stop it. We can just make replacement therapy, like in case of thyroid, or sometimes we have, unfortunately, no tools. Like sometimes there is so-called immunological defects in the ovaries. And in this case, even in young patients, we can observe premature ovarian dysfunction. And unfortunately, it's always the diagnosis which is verified retrospectively. So the decision is only the egg donation program. So there are a lot of types of immunological problems which associated in different ways with endometrial receptivity directly, if we have the process of pathology in the cavity of uterus, or indirectly if we have it in other organ which has an impact on progression of the pregnancy. Because, for example, if we talk about thyroid, abnormal functioning of thyroid leads to high levels of TSH in some cases, not in all cases, but in cases when TSH is very high, it provokes miscarriages, or it provokes infertility, but more often miscarriages. And also, it can provoke, in severe situation, great complication on health of the baby associated with this intellectual development. So for sure, there are many aspects we should take into the account. It's a very, very, thin material. It's a good question, but it really requires a new lecture.
Perfect. Thank you so much again. Of course, there are so many questions that you could simply just have so much more webinars on, right?
Yeah.
All right. So as I mentioned, there are like 2-3 questions left. So let's get to them. Okay. So and we will finish right after. Okay. So how do you detect endometrial antibodies? What is the effect of these on the development of a clinical pregnancy? What could be the problem resulting?
It's also it's by this moment it's a kind of our scientific work, because by this time we have already started this work about 4 years ago, and especially in patient, because as I have told, I not only work in private clinic, but also I lead as a tutor some scientific trials in university clinic. So we had initiated this process because we had a center for patients with immunological diseases. And in generally, when we talk about any immunological autoimmune disease, we the rule of detection and verification of disease is to detect antibodies to the tissue. For example, if we talk about autoimmune disease of thyroid, and I bet all of you have made this test at least at once. So you test your blood for presence of this antibody to thyroid. On the same way, we started to investigate the presence of antibodies to endometrium. And in some cases, especially the high prevalence was in patients with endometriosis, because the nature of the etiology of these diseases are associated with autoimmune defects. So in case of presence of these antibodies, we have observed the higher incidence of long-lasting infertility, of poor prognosis in fertility, and of multiple ineffective attempts. That's why the second case report I have demonstrated, it was also associated with this kind of pathology. And as a therapy, we have administered human immunoglobulin to stabilize this process. So we cannot fix it at all, but we can minimize the activity of this process. And this therapy was effective. So in some cases, when we have indications, recurrent implantation failure, severe autoimmune diseases and processes in the organism, we make this lab test. I'm not sure that in your country you have a lot of laboratories which can perform this, because usually the laboratory which make this test across the world are located in university clinics because it requires specific equipment and qualification of the specialist. So it's not a kind of routine test. That's why, but it's not really an often case. Don't think that it's recommended for everybody. Not, there are specific indications.
Again, thank you so much for providing such a detailed answer. I am sure it is all useful. And as I mentioned, there are like 2 questions left. So let me go to the next one. Can severe sperm morphology, motility very low, morphology no normal forms lead to miscarriage? Why doctors dismiss the importance of sperm quality and always insist that what is important is actually the quality of the oocytes and the age of the woman?
Very, very good question. Nowadays, to say the truth, yes, I think, traditionally maybe, but for many years, we have heard such an opinion that if there are some reproductive problems, cherchez la femme, the woman is to be blamed. But right now, we have a lot of data about correlation of unbenign prognosis and of poor prognosis and poor outcomes in couples with a severe male factor. And the data you have provided, we really should talk about severe male factor. So it's really approved, and we have a lot of trials that the age of the man and the quality of sperm has a great impact on the outcomes. Even in egg donation program, when the quality of oocytes is very, very good, we see that the result, the quantity and the quality of embryos differ depending on the quality of sperm. And 3 years ago, we have implemented that we have started to perform pre-implantation genetic testing in egg donation program. At that period of time, not everybody, but many physicians told us that it's not necessary because it's egg donation program and a good donor will produce always good embryos, but it's not the truth. We have a great number of cycles per year. So my team performs more than 7,000 cycles per year. It's a great figure. So I can share with you our experience that even in egg donation program, when we perform pre-implantation genetic testing, we see that among 4 embryos, at least 1 is abnormal in most cases. So, and we talk about egg donation program. So, for sure, these levels and these features you have provided about sperm quality, it's an indication, is an absolute indication for pre-implantation genetic testing. Another point that usually not only the quality itself, so this position that you have told us, motility, morphology, not only they play a role, not only these features can lead to miscarriage. There is a strong correlation between the level of DNA fragmentation in sperm with the level of miscarriage. So we have, and it's not only data of our clinic, it's a worldwide multi-center trials, that there is a strong correlation between elevated DNA fragmentation and elevated risk of miscarriage.
And fantastic. So thank you so much again for the detailed explanation to this question. As I've mentioned this, now it will be our last question for today. Okay, so let's get to it. How long does one need to wait between an endometrium biopsy and the starting of an in vitro?
Well, if we talk about, if you mean the starting in vitro, you mean the starting preparation for embryo transfer. So we just usually make on the following cycle. Usually our logistics is that way, that at first we make the preparation of the embryos, because it's the very one of the most limitation stages, because even in young patients, sometimes because of male factors, sometimes because of some individual features, we have some unpleasant surprises during embryo development. We work with biological material. We can and we have to create perfect conditions for embryo development. But unfortunately, we have the result during the procedure. We cannot make certain prognosis for the number of embryo outcome or the quality of embryo outcome. So especially in patients with difficult medical history or in patients of advanced age, we always start with ovarian stimulation, with individualization of ovarian stimulation, and prepare embryo. After pre-implantation genetic testing, when we have a conclusion that we already have enough embryos, why I tell enough? Because I always ask my patients, how many babies do you want? Sometimes they feel confused, because, especially when they have many ineffective attempts, because they tell me just I want at least one pregnancy, and I cannot think over the second pregnancy because I cannot manage the first pregnancy. But you should understand that you come to us for a solution, and we have to know the certain question, the certain inquiry. From the very beginning, I'm starting, to make the picture for you, to make like item of art, and I want to know how what item will make you happy. Sometimes patient want 3 babies. The couple want to have 3 or 4 babies. We need this information to make the individualized ovarian stimulation, to make the perfect doses for you, because there is a tactics called one and done. So it means we want to make just one ovarian stimulation in your life and have enough number of embryos to realize your dream of your full family. But everybody has its own understanding of happy family. Somebody wants just one baby, and it will be an unpleasant situation if we have 8 embryos and the patient has a pregnancy from the first attempt and we have 7 embryos rest, and it's confusing for the couple because they don't want babies anymore and they feel emotionally upset because they have a lot of embryos frozen. In other situation, if we have diminished ovarian reserve and we have just one good embryo, but the couple wants to have 3 babies, and I understand that she is at the age of 40. If we have good pregnancy from the first attempt, she will come after happy delivery, after recovery after delivery, she will come to me at the age of 43, and there is a very small chance to have another good embryo. So we should announce loudly our desires. After that, we can make a personal logistics and treatment plan. So after we have good embryo approved, we're starting to prepare the endometrium. In case, that's why I'm talking that it's better to make after ovarian stimulation, because during ovarian stimulation, we have to prescribe you some hormones very delicately, but it's still more than physiological levels. During this procedure, sometimes if you have the pathology in endometrium, it provokes its progression. So it's better to make this therapy and preparation not before ovarian stimulation, but after, very close to embryo transfer. So if you need just endometrial biopsy, it's usually needed to make diagnosis. The result of diagnosis will give us the response what kind of therapy you need and the durance of this therapy. In case the biopsy gives us the result that there is no pathology and everything is good, we can make embryo transfer just the following cycle after endometrial biopsy.
Amazing. Thank you so much for again answering that question. But already, as I've mentioned, it was our last question for today. But of course, just let me remind you that if you would like to get in touch with Dr. Diana and her team, all you need to do is simply go to the website that I am just sending to you right now, and you can simply click on contact clinic button, and you will be in touch very, very, very soon. So again, thank you so much, Dr. Diana. You have been excellent. Thank you for your dedication. That was really with all the questions as well, of course. And as you can see, I would like you to see this. You definitely need to see this. This is one of the best sessions I attended so far. Thank you. Great answer from a great doctor. This is a longer one. This is doctor is really knowledgeable and takes the time to give detailed answers. That is true, which is definitely appreciated. Very helpful. Have learned a lot. And here, good point. Communication doctor-patient can be also a cause of success or failure. I highly agree. Thank you so much from everyone
Thank
right
you so
here.
much. Thank you so much. It's a really pleasure to feel you to hear this feedback. And in the end, I just want to ask you once again, please take care about yourselves. I wish you good luck to everybody. I'm pretty sure that uh, sometimes we need just to believe that happy end will be in any situations. We create these circumstances, and believe me, we have enough. Actually, we really have enough instruments to help you. So I'm really happy. I'm really sure that all of us will manage healthy baby. We'll manage the pregnancy, good implantation, pregnancy, and normal delivery, and you will enjoy your happy family. Just sometimes it takes a little bit more time. Be patient, think positive, and everything will be good. Take care of yourself. Thank you so much.
Perfect summary for sure. I totally agree. We definitely need to stay positive, and definitely fingers crossed to all of you so that you will get your happy ending, as they say, huh? All right. So once again, thanks so much. Remember, this event has been recorded, so of course you will be able to again see it very, very soon. We will upload it as soon as possible, and all our events you can register even right now. You just need to go to myivfanswers.com, and that way you will be able to register to our all upcoming events. You can also find them on our YouTube channel, Facebook, and also Instagram. So I definitely encourage you to follow us there. And huge thank you once again, Dr. Diana. It's always a pleasure. It's not our first time, and I hope it's not the last one for sure.
Sure.
And well, I know it's quite late for you right now, so so
Yeah.
sleep well.
Thank you.
and
Yes,
and thank you again. Have a good night, everyone, and I hope to see you, of course, tomorrow, as we will be back on tomorrow. Sorry, at 6 p.m. UK time. Great to be here and helping you out as well. Have a lovely night. Bye bye.
bye bye. Thank you. Thank you.
Bye.